Hi there. Welcome to the InTouch webinar series. This is Kelsey Cleary. I'll be your host for this webinar. Before we launch, I want to provide a few important notices. You all have been auto-muted, so if not, please make sure that you mute yourself. At the bottom of your audience console are multiple application widgets that you can use throughout this neonatology webinar. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. You can expand the slide area by clicking on the maximize icon in the top right of the slide area or by dragging the bottom right corner of the slide area. Also, during the webinar, you will be able to enter questions in the Q&A widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar through the Q&A widget available on your screen. If a more complete answer is needed or we run out of time, questions will be answered later via email. Please note that the email address is feedback@intouchhealth.com. Again, feedback@intouchhealth.com. This webinar will be recorded and a copy will be available within 48 hours and will be sent to your email address. This webinar presentation should last about 60 minutes, including time for questions and answers. So again, thank you all for those who have joined this webinar, and I know some other folks will be joining in shortly. We know many are curious to learn about how neonatal telehealth is impacting healthcare. This is a perfect environment to learn and ask your questions. So we have the pleasure at InTouch of working with and supporting great neonatologists like the ones that we have present with us today to help extend virtual care. We're also currently supporting approximately 30 other health systems who have deployed and hospitals who have deployed virtual neonatology and perinatology programs across around 90 hospital locations. Several of us, including myself, can also personally relate to the need for neonatology, the kind of neonatology outreach that we'll be speaking about, whether we ourselves have had family or friends affected by premature birth or other types of complications. We can relate to those kind of lifelong effects that these complications have, and also the miraculous outcome that can often occur with the assistance of neonatal specialists. Now to kick off our neonatal panel discussion, I'd like to introduce Lee Wood, our panel facilitator. Lee Wood is the Executive Vice President and General Manager of Physician Services at InTouch Health and brings 25 years of experience in healthcare and hospital management. Throughout his career, Lee's worked closely with physicians and organization leaders across multiple sites and multiple states to develop and manage physician-provider networks with companies including HCA, Ameripath, and just prior to joining InTouch, Lee spent 10 years at Mednax, where he oversaw and worked closely with several large neonatal practices. Lee also facilitated a similar neonatology panel discussion during the InTouch Forum in 2017 with neonatologists from Mayo Clinic, St. Luke's, and Mednax, and will be helping facilitate discussions today. Lee, thank you so much for leading the panel today, and I'll hand it off to you.
Great, thanks, Kelsey, and good morning and welcome to everybody to our webinar on teleneonatology. We really do appreciate everyone taking the time to join our call and learn more about this growing field. You know, watching the development of teleneonatology programs really does hit home for me. As Kelsey mentioned, I spent 10 years of my career working in the neonatal field, and I believe the expansion of telehealth into this specialty is a critical factor in its success in the future. You know, I personally also have 3 amazing nephews who owe their lives to the dedicated professionals like our panelists and many of you in the audience who have devoted their careers to helping premature babies. I think as an industry, we're all aware that telehealth initially proliferated around telestroke. These programs and their success in delivering high quality, high acuity patient care remotely paved the way for the development of care pathways of other subspecialties like neonatology. There are some key similarities between emergent neurology or stroke and neonatology, both in supply and demand of the subspecialists. Like neurology, there is a recognized shortage of neonatologists in the United States. And at the same time, the increasing average maternal age, as well as our continual ability to treat younger and younger neonates at earlier gestational ages, that means a growing demand for the neonatal services and really an expectation that that care can be delivered in more remote areas. Additionally, just like telestroke, the outcome of the neonate often turns on minutes even seconds, and which is why it's so critical that every aspect of the teleneonatology programs are really well prepared and scripted. Fortunately, we have some panelists today who are forging their way with teleneonatology programs, and they're willing to share their experiences and knowledge in this growing field. Let me take just a couple minutes and introduce our panelists. First, Dr. Barbara Carr. Dr. Carr is with Mednax and St. Luke's Health System in Kansas City. Dr. Carr trained at the University of Missouri, Columbia Medical School. She did her residency at the Children's Mercy there in Kansas City and completed her fellowship in neonatology at Indiana School of Medicine. Dr. Carr is the medical director for both the Mednax Kansas City neonatology practice, as well as the neonatal program at the St. Luke's Health System. She's also the founder of the Heart of America Milk Bank, which has brought a much-needed supply of human breast milk to her community. Next, we have Dr. Bill Carey with the Mayo Clinic. Dr. Carey trained at the Warren Alpert Medical School of Brown University. He did his residency at Stanford University and completed his fellowship at UC San Francisco. Dr. Carey is the Associate Professor of Pediatrics for the Mayo Clinic College of Medicine, and he is also the Program Director for the Neonatal Perinatal Medicine Fellowship Program at Mayo. We also have Beth Krajewski with us from the Mayo Clinic as well. Beth is the Assistant Professor of Health Administration, Mayo Clinic College of Medicine, and the Operations Manager for the Teleneonatology Program. And last but certainly not least, we have Steve Kropp, also with St. Luke's Health System. Steve is a System Director of eHealth and Virtual Care at St. Luke's Health System, where he develops and oversees the system-wide telehealth program as well as an operational and a growth strategy initiative. I'd like to thank all of our panelists for spending their time with us today and sharing the knowledge for this important program. You know, before we get started with the panel presentations, I thought maybe we could watch a short video of a sample teleneonatal consult for those of you who may not have seen this. Let's go ahead and roll the video now.
Mayo Clinic Admission and Transfer Center, this is Chad RN. How can I help you?
Hi Chad, this is Julie. I need an emergency telemedicine consult for a preterm infant going to be born in Austin.
Okay. I just sent the page to our neonatologist, and I need to confirm you're calling from MCHS Austin, right?
Yes.
And briefly, what's happening with the baby?
We have a 28-week infant that will be born soon.
Okay. So, and that's our physician calling here. Let me put you on hold, and I'm going to get us connected, okay?
Okay.
ATC, this is Chad.
Hey, Chad, this is Bill Carey from Neonatology.
Say, I have Austin on the line. They have a 28-weeker that's not been born yet, and they want a teleneo conference. Can I connect you?
Yes, please. Thank you.
Okay. Go ahead, Dr. Carey on the line.
Hey, this is Bill Carey. I'm a neonatologist in Rochester. I understand you have a telemedicine consult for a 28-weeker.
Yes.
Okay, great. Hey, Chad, can you do me a favor and dispatch the neonate team down to Austin, and I'll connect via telemedicine right now.
Okay. Well, good.
Thank you. I'm going to stay on the line here until I'm connected, and I am live on video.
Yes, we have you on video.
Okay, thank you.
Thank you.
Hi, I'm Bill Carey. I'm one of the neonatologists at Mayo Clinic Rochester. Can you introduce yourself so I can understand who's on the team today?
Sure. I'm Dr. Fang, the pediatrician, and I have 2 nurses on my team today.
I'm Julie. I'm Lindsay.
Great. Good to meet you. I understand you have a 28-week baby on the way.
Yeah, that's right, and we're just getting everything ready. We have our chemical mattress and plastic wrap. We have our neo wrap set and ready to go, and I have intubation supply should I need it.
That's perfect.
Okay, great. Anything else? Because I think baby's about to deliver.
No, I'll go tend to baby.
Okay, all right. Okay, baby's out. Okay, we'll lift baby. Okay, we'll get monitors on. Baby's looking pretty apneic.
Puts that monitor on here.
We're just stimulating.
Looks like you're doing a good job of that. Still apneic.
Yep, still apneic.
Julie, can you check the baby's heart rate for me quickly?
Sure.
Heart rate 70.
Okay, it seems like the baby is apneic, so Dr. Fang, if you could please provide some positive pressure ventilation, that would be great.
It looks like, if you could please, tilt the chin back a little bit. Tilt the head back and lift the chin. There you go. That'll help with air entry.
Yep, our manometer is looking much better now. Thank you.
And why don't you breathe a little bit more quickly than you're doing right now? So maybe 50 to 60 times a minute.
2, 3, breathe. 2, 3, breathe. 2, 3, breathe. 2, 3.
How's the heart rate, Julie?
Heart rate's still 70.
Huh. I'm not seeing very good chest rise right now, so Lindsay, can you
That's
increase the
true.
peak inspiratory pressure up to 25 for me? How does
Okay,
that feel, Dr. Fang?
we're up to peak of 25, and the chest rise looks much better. I don't know if you can see that.
No, I can. It looks
But
good from here. I just wanted to get your take on it.
Yep, it looks much
That's
better.
great. How's the heart rate, Julie?
Heart rate's still 70.
Huh. How are the saturations?
They're 60.
Okay. Lindsay, if you could please dial up the FiO2 to 40%, and we'll see if that helps improve the heart rate.
Okay, we're there.
Yeah, and baby looks like baby's doing some breathing on his own.
Okay.
Heart rate's greater than
Saturations now,
100.
Lindsay?
They're at 72.
Okay, so coming up.
Yep,
And spontaneous breathing
It's-
looks like it's starting to happen. Kind of intermittent.
it is. It is. Yep, and Julie said our heart rate was greater than 100, so I think baby seems to be
Right.
responding.
Excellent. Yeah, do you want to try some CPAP alone for right now?
I think
Keep our
so.
FiO2 where it is? Okay,
Yeah,
great.
let's try that.
Thanks for getting the temperature, Julie.
Oh, you're welcome. It's 37.2.
Perfect.
And
So it
baby's
looks like the
breathing.
Baby's breathing pretty well.
Yeah. Yep.
Excellent. Saturations, Lindsay?
80.
That's great. They're moving in the right direction. Heart rate?
Heart rate's still greater than 100.
That's excellent.
And we're almost 3 minutes old, Dr. Carey.
Okay, perfect. So, look, I just got a page from our transport team. They're about 20 minutes out. Maybe one thing to do at this point would be to check a blood sugar, and if you can, place an IV to start some dextrose fluids. Does that seem like a good idea?
Yeah, I think we can do that. Thank you. Baby's still breathing well.
Perfect.
Great.
All right, that was a great video. I do understand that some of you may not have heard the volume on there. There was an adjustment on the lower side of your video to turn on and off the volume. If you were not able to hear that, please know on the replay you'll be able to hear the video. And it's important that you do so because there was a lot of great communication going on that really identifies what happens before the consult, during the consult, and the ability for the providers to interact, I think, is a crucial part of that video. I want to thank Mayo team for sharing this with us. And for those of you who might not have recognized our own, Dr. Bill Carey was the neonatologist beaming in, so he may be able to give us some color kind of on his perspective on what was happening in that video. But what I'd like to do is maybe shift a little bit now that we've seen the consult video and ask our panelists to tell us a little bit more about their specific teleneonatal programs at both Mayo and St. Luke's. Each uses the system a little differently, some overlapping and some unique aspects. So why don't we start, Dr. Carey, if you would begin, please.
Sure. Thank you very much. And good morning or good afternoon, as the case might be, to everybody for joining this webinar. I also wanted to quickly follow up with a comment about the video. I think that video is also available online and is searchable. So if before the meeting content is sent around to everybody, you're welcome to go online and find that. But we can get the address out to InTouch as well. Over the next few minutes, I'm going to provide a brief overview of the teleneonatology program here at Mayo, including some information about the system itself, patients for whom we provide remote care, and a little bit of information about the provider experience of our partners in the Mayo Clinic health system. So the Mayo Clinic teleneonatology program was developed and is primarily intended to support local care teams as they perform high-risk neonatal resuscitations in their community-level hospitals. Our program began as a pilot in 2013, gradually expanded in its scale and capability, and within just 3 years' time, we were able to provide teleneonatology services to each of the delivery hospitals within Mayo Clinic Health System, and there are 10. I have to say, I think it's the case that the growth and development of our program was made possible by really terrific partnership between the neonatologists in our Rochester hub site, the administrative and technical staff in the Mayo Clinic Center for Connected Care, and all of the primary care providers in the Mayo Clinic health system. So now let's take a look at our system, which we often refer to as a hub and spoke model. In Rochester, our Division of Neonatal Medicine is staffed by 8, or soon to be 9, neonatologists who are responsible for covering nurseries during the day at 2 campuses here in town. We have a 34-bed Level 4 NICU and a 22-bed Level 2, soon to be Level 3 nursery, which is co-located with our high-risk labor and delivery service. Between our inborn population and outborn patients from Mayo Clinic Health System and other referring hospitals, we have approximately 400 admissions to the NICU each year. And that number has increased steadily over the past several years, I think in part due to the establishment and development of our telemedicine program. The spoke sites in the health system, again, there are 10, most of which operate Level 1 nurseries, but we also support one site with a Level 3 nursery in a hospital that has an advanced perinatal service. Together, these hospitals deliver between 5,000 and 6,000 babies annually, with the provider coverage model differing from site to site. So there isn't one standard throughout our health system. Some may have pediatricians or family docs on call from home, whereas other hospitals may have these same sorts of staff members in-house 24/7. But that is in the minority for sure. The type of OB and anesthesia coverage also can differ from site to site. So in some rapidly evolving emergency cases, we may partner with a labor room nurse or an emergency medicine physician to conduct a teleneonatology guided resuscitation. And in fact, if I recall correctly, the first case that was ever done actually took place in an emergency department in one of our Level 2 hospitals in the health system. I think the information in this slide is a little bit dated, but it does accurately reflect the current state of our teleneonatology practice. Our partners in the community most often activate the teleneonatology system so that we can assist with the resuscitation of a preterm baby. And again, because each hospital has its own individual capabilities and level of nursery care, we may be called to help with the resuscitation of a late preterm baby in some hospitals, but not infrequently, we're called to help our partners manage extremely premature babies as well, all the way down to 22 weeks. Respiratory distress and advanced resuscitation of term babies are the next most common indications. But I think if you take a look at all these indications, you can see that in general, they're similar to those that would prompt transfer of an outborn baby into your own practice. So the question then is being in the room, remotely so to speak, improve a larger system of care and promote better outcomes for our patients? So now that every baby born in the Mayo Health System has access to a neonatologist, we've accumulated enough cases to determine the manner in which teleneonatology can improve the quality of resuscitation. Care processes clearly are improved, especially for preterm babies, it turns out, with local providers being more reliably monitoring and managing patient temperature, blood glucose levels, and even blood gases. We've also found that early activation is associated with better resuscitation outcomes, and this has actually informed our practice. We encourage our partners in the health system to call us even before a baby is born, provided time and resources permit that. And beyond knowing that we've improved the care of an individual baby, there are 2 system-level benefits that I've highlighted here on this slide. Since the establishment of the teleneonatology system, there have been no settled birth injury cases from any of the hospitals in the Mayo Clinic Health System that have teleneonatology in place. This is terrific support for local providers, but it's also a testament to their effort in this process. And I'll describe that a little bit further down the line. Teleneonatology also can improve patient experience, perhaps most especially for the 1/3 of patients and families whose babies are able to stay in the delivery hospital following a resuscitation that was guided by a Rochester-based neonatologist. So what does this all look like in real time? So the Mayo Clinic teleneonatology program covers an area of approximately 15,000 square miles. So as you think of your prospective hub and spoke model, you might keep that number in mind. But to me, more meaningful on a case-by-case basis are our transport distances, which average about 90 miles. And as you can see, it can exceed 120 miles in some cases. And not all of these spoke site hospitals are accessible by major interstate highways. So a 90-mile drive can easily exceed 2 hours when the weather is bad in the winter, or when we can't fly to retrieve a patient during the summertime because of storms. This is particularly important for our system of care here at Mayo, as the Rochester hub truly is the closest resource for many of the smaller communities we serve out in rural Minnesota and Wisconsin. So I cannot emphasize enough how important it has been for us to have such great partners in the Mayo Clinic health system. At each of the spoke sites, local leadership has made sure that labor and delivery staffing and resources are compliant with NRP guidelines, that the telecommunications infrastructure is up to date, and that the staff are made available to engage in regularly scheduled mock codes or as-needed debriefing systems to test our system and to keep up our skills. The local providers are not only willing to work with us neonatologists, they truly want to work with us. They recognize the need for teleneonatology support, but more than that, they value the opportunity to collaborate with us. They consider teleneonatology to truly be a collaborative practice, one they would recommend to others who want to improve the quality and safety of care in their neonatal system. Before I close my part of the webinar, I wanted to mention how we've incorporated teleneonatology into the fellowship curriculum here at Mayo. So if there are some of you at academic centers, this might be of interest to you. During our fellows' first year, they earn their certification as NRP instructors and then progress through teaching mock codes with our partners in the health system before performing supervised teleneonatology consults, just as they would be supervised by our faculty in the delivery room. And there were three main reasons for us to bring our fellows into the fold once our clinical program was well established. And first, and probably most simply, teleneonatology is a routine part of our clinical practice here, just like our labor and delivery service and our NICU are part of our clinical practice and learning environment. It also allowed us to innovate how we teach and assess our fellows' competence in a variety of domains, and it's been a great way for us to engage our fellows as teachers and get feedback from them about their teaching capability. And last, because we really do believe that teleneonatology is part of the future state of our field, it would only make sense for us to prepare our trainees to practice and lead others when they go out into their own independent practice. So I'll close there and turn it over to Dr. Carr, I believe.
Actually, appreciate that, Dr. Carey. Really quick, let me introduce a couple things. First of all, thank you for sharing the Mayo's program. And I think two things that stand out to me were probably your last two slides. The amount of preparation that you do at the spoke sites. I think as we know, every minute counts. It's really important that you have a secure and reliable system in place to get to those babies quickly. And then really exciting about what you're doing with the new fellows and the new neonatologists coming out with that early training in telehealth. So thank you for that, that overview and the information. I know we've got some questions already popping in. But Dr. Carr, would you actually lead us through your program at St. Luke's and tell us a bit more about how you use the systems?
Surely, I'm happy to, and thank you and Kelsey and the rest of the wonderful people at InTouch for inviting me to speak today. And good day to everybody that is on the webinar. I'm really happy to be here and share my group's experience in using telemedicine within our neonatology practice. As Lee said, I'm Barbara Carr. I'm a neonatologist in Kansas City, Missouri, and I'm the medical director for Pediatrics Medical Group of Kansas. One quick disclosure and disclaimer that although I do work for Mednax, I'm not here as a representative for them. I'm really just here to share my group's experience, and I have no financial disclosures. wanted to give you some background information about my group. Again, we're a pediatric medical group of Kansas. We consist of 9 neonatologists and about 20 nurse practitioners, and we provide neonatal services for the St. Luke's Health System. Within that system, we cover 4 NICUs in the Kansas City metro area that collectively have about 5,500 deliveries per year. And we also support 3 more rural hospitals outside of the metro area with telehealth services. The St. Luke's Health System consists of about 12 hospitals that cover a pretty wide geographic area, similar to the folks at Mayo. We span about 22 counties and about 10,000 square miles with a driving radius of about 100 to 150 miles from downtown Kansas City. And again, we have 4 NICUs within the metro area, the largest of which is a 48-bed level 3 NICU that we cover 24/7 with an in-house physician and neonatal nurse practitioner. The remaining 3 metro NICUs account for an additional 25 beds and consist of 2 smaller level 3s and a level 2 NICU. And all of these 3 other sites are covered with an in-house NNP and an out-of-house on-call physician. And our more remote delivery sites are covered by a mix of family practitioners and pediatricians. Several years ago, as the health system itself experienced growth in delivery volumes and the census and acuity of the NICUs at our 2 of our metro sites, we became concerned as a practice about our ability to adequately support each NICU at the level of service and care that we wanted to provide. We really wanted to ensure that patient safety would not be compromised due to response times and that there would be adequate supervision for a young and growing NICU staff as they cared for sicker and sicker babies. And this is very challenging due to the physical distance between sites with drive times that can range anywhere from 20 to 45 minutes depending on traffic. Kansas City, of course, also has potential for bad weather and also impacting travel negatively. In addition to patient safety, after we had a near-miss accident with one of the physicians in my group, we became increasingly concerned about physician safety. Driving at late hours, bad weather, or just distracted driving when they were responding to a code situation or emergency delivery. And we really didn't want our physicians to be on the phone trying to assist and pay attention to a code situation and trying to pay attention to the road and driving at the same time. Didn't feel like that was really any good for anybody. So we improvised. We set up dedicated code phones attached to radiant warmers in the delivery rooms of each of these 2 sites. This allowed a neonatologist to be available on an immediate basis. And while we felt it greatly improved the patient and physician safety, our response times, and our overall comfort level, it really wasn't entirely smooth. We had issues with reliability, as you might imagine. It was highly variable depending upon which hospital we were in, where in the hospital we were. The sound and the image quality would very much be subject to whatever those situations were. The phones could be bumped. We could lose visualization of the baby. And we were also, just from a malpractice standpoint, concerned about the phone falling into the bed and hitting the baby. Fortunately, never happened. But we knew we needed a better way. So we then turned to the hospital, which we knew already had a robust telemedicine program for adult patients, including EICU, stroke, psych, and really began to explore the feasibility of using this in the NICU. And about that same time, we were approached by med-ped physicians at one of our rural sites requesting some backup delivery room support for emergent deliveries. So we worked with the hospital and InTouch, got our equipment set up, and very quickly we got up and running with our NICU telemed program officially. Our group then contracted with another hospital within the St. Luke's Health System, which was a small level 2 NICU. And with the positive experiences we'd had up to that point, we actually planned to cover it with a slightly different model, with the plan to cover it exclusively with an in-house NNP and a telehealth neo. We developed really 2 models of use. The first, an internal use within the metro to incorporate our daily roundings, on-call and emergency coverage, as well as some peer-to-peer consultation. And secondly, looked at it from a growth perspective, looking to attend deliveries remotely and allow for remote consultations as well. And I'm going to expand on each of these. So internally within the health system, we have one site that I mentioned we cover nearly exclusively with telehealth. So that attending physician on a daily basis remotes in with the NNP and receives report on the baby. There's a visual assessment of the baby and a remote physical assessment that can include auscultation by using the stethoscope attachment and or a directed physical exam by the NNP, followed by a discussion of plan of care. We also speak to the baby's parents at the bedside, reviewing findings, plan of care, answering any questions that they may have. And we've really found this to be a very efficient way to maintain contact with them. Even if they're not there at the time of the initial evaluation, it's very quick and easy for us to remote back in and talk with them later in the day. One unanticipated benefit that we had of having telehealth equipment was the availability and ease of a peer-to-peer consultation. Throughout our health system, it's now very easy if we want a second opinion from someone within our group. Another neo can just very easily remote in, assess an infant, and if needed, discuss with the family. And it all happens in a very rapid, timely fashion. And additionally, it allows for a more experienced nurse or respiratory therapist to assist their peer with infant care. Our additional internal use is on-call coverage. For infants admitted after the attending has left for the day, it allows us to remote in and do an initial and sometimes repeat infant assessments, discuss things with the staff and with the family. And by doing this, we can readily determine if we need to go in and assess the baby in person immediately, or if the baby's doing okay, maybe we still want to go in but delay until after rush hour traffic has cleared, or if it's in the middle of the night, maybe we just know we can wait until the morning. We can also meet and begin to establish a rapport with parents of a new baby rather than waiting until the following day. Emergency coverage was really the initial key driver of our internal use. The in-house physician of the main site now remotely attends any emergency delivery or code situation or provides support during any emergency procedure with the in-house NNPs across the system. It allows for the immediate presence of the neonatologist and immediate support for the on-site medical team. The NEO provides supervision and assessment of the baby, mobilizes the transport team as needed, which shortens the time between birth and access to a higher level of care. The NEO can also talk with the family while on-site, while the on-site team is actually caring for the infant, and that really improves communication as well. And during this, the out-of-house NEO can be driving safely, not trying to run a code while driving, and knowing that baby is being cared for. At the Growth Initiative, we've also seen telehealth opportunities in this area. We also want to be able to use this to improve care of babies in remote areas. And we offer remote delivery attendance and consultative services for well baby nurseries and emergency departments to those remote sites. And again, this allows for immediate neonatology presence to assist an on-site medical team that may lack the experience and or comfort in resuscitation and care of sick infants. We can we can also assess the need for transfer of that baby versus the baby that can be monitored at their home site close to family. And staying at that home hospital can obviously have a huge impact on families emotionally and financially. If the baby does require transfer, we feel it makes it easier for the family if they already have a name and a face of the physician and the team that's going to be caring for their baby. And actually, I always remote back in with families after the baby's arrival to update them and show them where their baby's room is going to be. It's really also proven invaluable for that same peer-to-peer consultation, RT to RT, RN to RN, as these staff are typically not comfortable with the care of a sick neonate, and they really do appreciate the assistance. And overall, again, we feel it really results in significantly improved baby care and is a satisfier for families and hospitals. And we've also seen telehealth as an education for opportunities similar to Mayo. We use it for our mock codes, and we do hope to use it for some additional education opportunities in the future. I wanted to give you a quick flavor of the time that's involved for our practice. Looking over the last 2 years worth of data, we've seen increasing use by our team with this as the comfort level has increased. Our 9 neonatologists had an average of about 68 telehealth encounters, with an average time for encounters ranging anywhere from 7 to 12 minutes. More intense situations obviously require longer time periods, and our max times for encounters have ranged anywhere from 1 to 3 hours. When we look at our coverage sites, which encompass, again, a 2 to 3 hour driving radius, we really feel it's resulted in significant time savings and improved our job satisfaction as well. I wanted to close with just a few final thoughts. Telehealth is a tool that was easily and quickly adopted by me and my partners, and it's now really an integrated part of our practice. And as we look to the future, the stark reality, I think, is that there's going to be increasing physician and NNP shortages. I'm part of a national initiative at Mednax to address these shortages, recognizing that we need to rethink how we're providing NICU services, be more nimble, resourceful, and know that practicing at the top of licensure is going to be critical to this, as well as is the need for appropriate supervision. And telehealth technology, I think, allows for this supervision. It allows for improved family satisfaction and, most importantly, improved baby care. I also wanted to leave you with some beginning resources regarding telemedicine to assist you. It's important to know that the laws that govern telehealth vary markedly by state, and it's a rapidly changing landscape. So hopefully you'll be able to use some of these as initial steps to get you information about where you live and to assist you as you begin to explore utilizing telehealth. And with that, I thank you for your time, and I really hope that this has been helpful to see my group's perspective on the use of telehealth in the NICU.
Perfect. Dr. Carr, thank you very much. I think it's intriguing how you've incorporated the system not only into the emergent interactions, but also your daily activities. It really becomes, and my hope is that at some point this will become another way to provide neonatal health care and not just telehealth. It's really been incorporated. So I appreciate both of you, actually, Drs. Carey and Carr, in sharing these aspects of your program. I'd like to, at this point, open it up. I know we've got a few questions coming in, but open it up to questions from the audience. If you have any questions, please submit those through the webinar. There should be a little button at the bottom that you can open up the Q&A. If we can't get to all of your questions on the webinar, we will respond by email or do some follow-up as well. But while we're waiting for some of the questions to come in, maybe we can start, Drs. Carey and Carr, with telling our audience what one or two of the main goals that you each were hoping to achieve in your program when you set about implementing it, and what results you achieved relative to those goals. You want to start with you, Dr. Carr?
Sure. I really, when we first started really emergency coverage to improve care and safety for the patients and for us, that was really kind of our overall arching intent and goal. When we do this, not that the NNPs aren't skilled out of our remote sites, but when they are at those sites that don't always care for a 24-weeker or a 28-weeker, they really have increasing demands on their skill sets and their time in terms of what they have to do and be more directed. And so having the neonatologists there can really augment that overall process. They really appreciate having us be there in that immediate sense, and we, again, appreciate being able to get in with our eyes on and visualize that baby. And then I think secondly was just the expansion piece of it, so that we can really offer improved access to care for babies, whether they're at one of our metro sites or anywhere else in Kansas or Missouri. We have this technology, and I really think it behooves us to use it to improve care. We've utilized it with great success, walking them through procedures, deliveries, and have allowed some babies really to stay close to their home site that would have otherwise been transferred. But we have more to do. We're continuing to work.
Great. Thank you. Dr. Carey, from your perspective?
Sure. I think sorry for a bit of feedback. I think our original intent was to improve the safety of care processes in resuscitations and hopefully to improve outcomes. And it's a lot easier to assess how we've improved resuscitation processes. It just takes more cases to know whether or not we're making a big difference for some kids. And anecdotally, I would say we surely are. The other primary or initial intent was to really build relationships with some of the care providers out in the health system. These hospitals function very autonomously, and they do have a choice in where they can send their patients, whether it's up to the Twin Cities or different hospitals in different larger cities. But in establishing this telemedicine link and working with them in some pretty high-intensity situations, we've really strengthened relationships that we started building through outreach processes years before. And a nice unanticipated consequence was that because I think the pediatricians and family docs have a good sense that we are there for them and there with them when we're doing our work together, that they've been able to more confidently increase the level of care they provide in their nurseries, not beyond the scope for which they're approved, but working within their level of care to provide perhaps inpatient care to slightly younger babies than they might have done in the past. and treat certain diagnoses they may not have treated in the past, knowing that we can support them on an as-needed basis. And that's been a really nice, again, unanticipated consequence of starting these programs.
That's great. Well, thank you very much. Again, thank you both for that. We are starting to get some questions rolling in, but I'd like to just give two quick questions to our other panelists, if we could start. Beth Kranowski, can you discuss some of the key operational aspects of your program that you had to address kind of pre-rollout to make sure that you had a successful program?
Sure, thank you. Well, there's really three things that we touch on and we share often. The first is buy-in, and I think Dr. Carey just touched on it quite well. Is you not only need buy-in from your provider group, but you also need buy-in from the spoke sites, or the originating sites, and the leadership teams across both organizations. So luckily at Mayo Clinic we have currently all of our internal sites are originating sites, and we are within the Mayo family. But it's interesting to see how you have to change the dynamics of the conversations, and you have to share different information with leadership teams to motivate them and to get their buy-in versus clinical teams. The second is we focused on our workflow and making sure that we had a really sound workflow, everything from patient registration, documentation, all the way through to service activation and the actual consult, to make sure that we, one, were able to deliver timely and effective service, and then two, to make sure that we're compliant and within the guidelines that are provided to us. So we actually at Mayo Clinic have a compliance manager that focuses solely on telemedicine initiatives. So for every implementation of telemedicine, regardless of it's teleneonatology or other telemedicine services, there's a compliance checklist that's completed, and then our legal team reviews it to make sure that we're staying within the boundaries, so to speak. And then third, we have a very large, there's a large need for both operations and technical support. What we get from InTouch is wonderful, the amount of support and the proactive monitoring of the devices, but that only gets us about a quarter of the way there. There's other opportunities for support that need to be in place, from what Dr. Carey mentioned around the simulation, the training. Those are all opportunities for us to identify if maybe someone had a software upgrade on their laptop, and that needs to be modified, or the software needs to be adjusted to work properly. So our technical support, our operations support, those are also items that we made sure we had in place and we could iterate on as we went live.
Perfect, thank you. And finally, Steve Kropp, I know we have a lot of audience members that sit probably in a similar seat as you do from a health system perspective. And there's often a lot of competing wants and asks and points of view. What were the key issues that were important to you as you developed the overall program for St. Luke's, and how did you create a cohesive telehealth strategy?
Good questions, and ones that don't oftentimes have easy answers. It's a good situation when you have a number of different providers coming to you and asking for, the use of this technology. But then you have to figure out a couple of key things that we really focus on, and that is how portable is that technology, and how well does it integrate into your current and some of your emerging workflows. Two issues that we had to address as each one of those specialties come. Really, in all honesty, neonatology was an easy one because Dr. Carr and her team were very motivated. And if you have a team that has a vision and they're motivated to make this happen, I think as she pointed out, to begin with, to address emergent care for these babies that are in some of these outlying areas with maybe fewer resources, that makes a very easy fit because you can realize quickly that it's going to integrate into their workflow because they have a desire for it to. I think the other part of the question is that sometimes is asked is who pays for that equipment on the far end. And in most of our situations here, I think we're not unique in that outlying facility, they're able to budget for and capitalize that equipment on the far end. I know there are some unique situations if they're critical access where a larger facility or a metro facility may be able to provide some of those key technologies. But for the most part, our facilities that we work with in the region, they purchase those telehealth units, the InTouch units that they use on the far end, and then our physicians have access to those units across the board. As far as the question leads to how to create a cohesive strategy, it's one that doesn't happen overnight. One of the things that we did with St. Luke's is we developed an e-governance team, and within that e-governance team, we tried to identify individuals who obviously had a vision for what telemedicine and e-health can do, but also had a flair or an idea about what each specialty might need within the scope of our practices. The network reliability was mentioned. We looked at how our technology that we currently had within St. Luke's and how it interacts with our Epic medical record. We haven't said much about that, but that is a unique part about how telemedicine continues to work and how you can level set and bring some balance to that program across the board. I think the key issues that we looked at were whether it's an e-hospitalist program or neonatology or maybe an infectious disease. Each one is unique in being able to provide a technology that has the ability to serve each one uniquely from the needs of the patient, the needs of the provider, and also the needs of the family is what we were able to do through the InTouch product.
Excellent. Steve, thanks so much. So we have a question from the audience, and maybe Drs. Carey and Carr, you could each weigh in on this. And the question is, what technology do you feel is necessary for the neonatologist to adequately see the baby and the situation in the room kind of simultaneously? Dr. Carey, do you want to start?
Sure. Here at Mayo, our system is designed to enable us to work within the NICU at a wired desktop and at home via a laptop, to which Beth alluded a few minutes ago. But we also have, just given our practice model, an at-home call coverage model. We also have the ability to use personal electronic devices to be able to immediately log in to the system and visualize a baby and a care team if there's an emergency that's been called through. Some of you were having some difficulty with audio, so I'll quickly recap the video, what the video showed earlier in the webinar. But effectively, my pager will go off and indicate to me that there's an emergency neonatology consult. And at that very moment, if I'm 5 minutes perhaps from my desktop at some other location in the hospital, I can duck into a room very quickly and open up my iPhone and get connected with the local care team and understand exactly what the circumstances are, how much time we might have to prepare together. And if I'm logging into a computer, I can stay connected that way and fairly effectively. And sometimes I've actually done when I've been mobile around town, I've actually been able to conduct a pretty effective telemedicine resuscitation from a smartphone. It's remarkably good technology on our end. The light devices that are deployed in the health system work terrifically. They fit into the care space quite well. And in general, it's quite easy to communicate with the local team to ask them to optimize the location of the device relative to the patient or care providers, depending upon what care processes are being engaged. And it's quite easy to have pretty meaningful conversations with families through that device as well.
That's great. Thank you. Dr. Carr, I know that you actually attend high-risk deliveries with the system. Can you talk about how the platform enables you to be present in that and what you find?
Sure. So I would echo what Dr. Carey has said. It's in terms of the technology. You can use either a laptop, your phone, or even a tablet or iPad of whatever sort that you have. All of them are equally effective. People will develop their own personal preferences for them. From a thing that I would add to that would be you have to have really good broadband within the hospital system itself, and you have to be able to get connected and to maintain that connectivity. A good headset is also helpful. For us to get in and see the babies, we really have to focus on, we usually actually put the robot through a similar site where we stand. And when we would be there in person, so that's how we kind of turn the robot and we can view all of the people that are caring for the baby at that point. And the other thing that we focus on is noise in the room, because the microphones are so good with the robot that it really will pick up kind of all of the sound out there. And so that was one of the training pieces that we went through, was to have people focus on the noise level in the room.
Great. Appreciate that. We have a lot of questions on billing and how the billing may work for the remote sites. Beth, can you give a little bit of insight when you have a consult and a baby that may not be transferred to the main site? Are you able to bill for those, and how does that work within your system?
Sure. I'm getting a lot of feedback. Our originating sites, they're able to charge the technical fee for or the facility fee for the hospital. Within our own Mayo Clinic health system, our providers document the level of care and the amount of time that they spent. That goes to our coding team, and then our coding team looks at all the CMS regulations and rules that apply to telemedicine and apply the appropriate codes based on those rules. So while we do bill for these, and we're starting to see some reimbursement, but it's very variable as to what codes are used for what cases, because we can do everything from a non-critical consult to a critical consult that ends up transferring. So if you have a coding team or a billing and compliance team, I would highly recommend you engage them to help set up your billing processes for your system. For our external sites, we are on a subscription model. So the hospital pays Mayo Clinic professional and technical fees, and then they are able to charge the patients the technical fee, or bill the patient the technical fee. We do not allow their organization to charge the professional fee for our neonatology professional billing, nor do we. So we do not charge the professional billing for external patients that are seen, because those are covered in the subscription fee, and it would put our providers at risk if the external organization was billing on our provider's behalf.
Fair enough.
Does that answer the question?
It does. Thank you, Beth. Thank you very much. A couple of quality and clinical questions, and I'm going to throw those back to Drs. Carr and Carey quickly. One is, what types of metrics do you track in your programs? And the second, and I'll join these for the interest of time, the second was kind of in the periphery equipment. Other than stethoscopes, what are you able to access or focus in on during the consults? Dr. Carr, do you want to start?
Sure. So I think some of the things that metrics that we can follow are things like temperature, first glucose, initial blood gas of the baby, of course, is on the ventilator. Rates of pneumothoraces, that's a big one that we follow, making sure that our pneumothoraces are not increased, especially at our remote sites, and intubation attempts, as well as line placement attempts. And from the other add-ons in terms of other ways to assess the baby, the only one that we have is the stethoscope attachment, but I will say that the video quality of what we have is superb. I have no doubt that the color that I'm seeing is true on the baby. I can zoom in and see an umbilical line placement closer than I'm doing it if I'm doing it in person. So I think that visual depth and just the acuity of that vision is excellent, and really allows me to feel like I've got a really good sense of what's going on with the baby.
Excellent. Well, thank you, Dr. Carey.
I would agree with Dr. Carr. One of the findings that's pretty important, physical findings that's pretty important when we're doing these consults in term babies, is degree of, or looking for any evidence of encephalopathy. So the question of how confident do you feel in your ability to see the patient and understand what's going on for him or her I feel very confident in my ability to ask the local providers to do a couple of maneuvers to be able to demonstrate to me tone, posture, and so forth. And I feel like in the context of, maybe some late fetal heart tone decelerations, acidosis identified on umbilical cord blood or patient blood samples, I can do a very reliable exam for encephalopathy and then begin to guide the local team through passive hypothermia in cases of term or near-term birth asphyxia before our transport team arrives to start active cooling. So when you talked about minutes being important earlier in the webinar, Lee, that's the kind of thing that the quality of the audio and video can allow you to do. It can make you feel very confident, even in the highest risk situations, to provide appropriate interventions for these kids.
Excellent. Well, thank you very much. And I do want to thank all of our panelists. We're about wrapping up our time today. I want to thank you all for your participation and the time that you put into this and sharing your knowledge. I know there may be some follow-up questions after the webinar that we'll send to you and ask for some input, because I think there's a lot of interest here. Real quickly, Kelsey, I know some of the development team has been working on some great new platform tools and with application directly to tele-neonatology programs. Do you want to just update us on a couple of those?
Yeah, sure thing. So thank you, Lee. And thank you, everybody, for submitting your questions. So in the Mayo Clinic demonstration that we all saw, we noticed a device that's currently used by approximately 30 health systems and hospitals that have deployed virtual neonatology. This device is also used for many other clinical use cases, including neonatology. It offers neonatologists free range of motion by turning the remote device screen themselves to obtain different views in the room, such as monitors, the baby, or simply to turn, look, and speak directly to a care team member. And a fisheye camera is also available for peripheral vision, and an HD optical zoom camera enables that neonatology specialist to view the baby close up, as you saw also in the demonstration video, as well as how you see it in this photo right here. The light represented here is the Light V4 version, which is the newest release of the Light. That offers a new array of features, including interactive touchscreen capabilities, a thermal camera, an HD fisheye camera, and several more features to enhance the user experience overall. We're also excited about the newest development that's being tailored for neonatology use cases specifically. The boom arm variant of the InTouch Light V4 is a device that's being built to enable neonatologists to obtain an unobstructed, clear view of the neonate from over the care team while being minimally invasive and simultaneously enable the virtual specialist to view the surrounding monitors or view the local care team without losing their view of the neonate, which is most important throughout the intervention. So we just wanted to summarize those points, but again, this now wraps up our webinar. We want to thank all of you, our attendees and our panelists, particularly the attendees, for submitting all your questions. Remember that if you'd like a question answered, or if your question you felt wasn't answered thoroughly, please do submit your question to feedback@intouchhealth.com. A recording of this webinar, again, will be sent out to your email address. You can also find the demonstration video that you saw by searching Mayo Clinic Tele-Neonatology Program online. We also want to give a special thanks again to our panelists, Lee Wood, Dr. Carr, Dr. Carey, Steve Kropp, and Beth Krajewski for sharing your experiences, and we all look forward to seeing your programs touch more families' lives. And the same wishes goes towards all others on this call who either have virtual neonatology programs or who are looking to initiate this special service. So again, we hope you all have a wonderful rest of your afternoon, and thanks again everyone for joining.